And our aims are to support research that leads to a better understanding of this group of diseases, to improve diagnosis, and of course to find treatments, whether they're to slow the progress of the disease or to modify it or to prevent it. To be honest, anything that we can do that will improve the condition will be an advance. And of course, our last aim is to share information, and that's the nature of the webinar today. We support research activity in universities in the southwest of England and in South Wales. And as a charity, as you can imagine, we rely on donations, and we rely also on fundraising activities and various events. Now, the latter, of course, we haven't been able to run for the last few months. So life is difficult, and at the moment we can't fund all the research that we would like. So I hope that you'll remember us, remember Brace, when thinking about the problems and the issues around dementia. So the purpose of the meeting is for you to be able to obtain some more information, we hope, about dementia, and then also have the opportunity to ask questions, and I'll do my best to field as many as I can. We're going to run the meeting in 3 parts. There'll be a little bit of housekeeping and then an introduction from me. And then we're going to broadcast a presentation by Dr. James Selwood. Unfortunately, he can't be with us, but we do have this recording of his talk. It's an illustrated talk. James is a medical doctor. He works with Professor Liz Coulthard in the ReMemBR Group at Southmead Hospital. And that group specialises in people who have memory difficulties, which may be leading to dementia, and they're involved not only in providing clinical support, clinical services, but also research in the form of clinical trials. And Brace, we're very happy that we're able to support them. So James's talk will last about 30 minutes. He will talk about the 4 main types of dementia and how we can help people who have the disease. And then the third part of the webinar will be the opportunity for you to ask questions. Now, you may have a question already, or one might crop up during James's presentation or what I have to say. Now, if you have a chat facility on the device that you're using and you're happy using it, perhaps you'd like to send your question as a chat message, then Emma and Amanda will be logging those and we'll come to it in the question time. If not, just jot something down on a piece of paper and keep it with you. And then at the end of James's talk, I'll say how that you can, if you like, let it be known to us that you've got a question. So just log it for the time being and we'll come to it later. Now, a couple of other housekeeping things. I have to say we are recording the webinar, but only the main speakers. So there's no recording of the individuals. We will keep a track of your questions that come in through chat, so we have them for the Q&A session. But afterwards, in order to obviously respect everybody's confidentiality, the recording will be destroyed. Now, at the moment, everybody has been muted so that when the dog barks or the doorbell rings, you don't suddenly become the star of the show. And we've also turned off the video. Now, if at this stage you're happy to switch back on your video, that's fine, that's up to you. But during the webinar, we'll keep everybody muted. We're not trying to keep you out, but of course we'll bring you in for the questions, but for the time being, hope that you're happy that that's the state of play. So we'll go back to the batting order and I'll just give a little bit of scene setting background. we've all got concerns about dementia, and we all have some knowledge about it, and that's why we're here. That's why we've come to the webinar. And we're all very aware of the impact of this distressing group of diseases. It's not my plan to have lots and lots of numbers, but we have to remind ourselves that dementia now is the #1 cause of death in the UK. Each year, 70 to 75,000 people die with dementia. And in order to help perhaps visualize that, that's a town the size of Taunton. So that's Taunton every year. But we have no treatments, no effective treatments. We have nothing to slow the disease. All we have is some medicines that will help to ease the symptoms, but that only works for a limited period of time. So we really have got not very much to offer. And that is despite a very vigorous research effort over the last 25 to 30 years, involving charities such as Brace, the Alzheimer Society, Alzheimer's Research UK, government money from what was the Medical Research Council, now the National Institute for Health Research. And of course, it's not just the UK, there's an international effort directed at trying to find answers to some of the questions. People often ask, well, why has progress been so disappointing compared with, say, infectious disease? We can now control polio, we can control smallpox, we can control a whole range of infectious diseases effectively. We haven't stopped cardiovascular disease, but we can now prevent a large proportion of strokes and heart attacks. And should they occur, we've now got very much more effective treatments. And of course, there are many success stories in the cancer field. There are many types of cancer, and some do not have the fear that they once had because we now have ways to treat them. So why is it that dementia is lagging behind? Well, to be frank, for a long time we, and I say we in the very broadest sense, we failed to acknowledge the disease. It's been swept under the carpet. Certainly in my parents' age, there would have been a stigma to have to say that a member of the family had dementia. And instead, patients were hidden away in perhaps a private care home or in the geriatric wards of what were then known as mental hospitals or mental institutions. So dementia was not a public issue. It was not something that people talked about. It was not a health issue over which there was very much lobbying with government. So we're having a lot of catching up to have to do, and that's why the work of Brace is so important. As many of you will know, the most common form of dementia is Alzheimer's disease. And although Alois Alzheimer was a doctor, he was a psychiatrist, his main interest was in neuropathology. His drive was to try and study under the microscope the changes that occurred in nerve tissue with various diseases. So it was, in a sense, quite natural to him when he had the opportunity to study the brain of the dementia patient that had really made a very strong impact upon him. It was a lady called Auguste Data, and she had a very severe form of Alzheimer's disease at a very early age. He first met her when she was in her early 50s. She died in 1906, and Alzheimer had the opportunity to study her brain post-mortem. And from that, he hoped he might find clues to the cause of the disease. So when he carried out the post-mortem, the first thing that really struck him was how much the brain had shrunk, what we call atrophy. The second thing that struck him was when he looked at pieces of the brain under a microscope, and he saw two groups of abnormal change that wouldn't be there in the brain of a younger person. The first thing he noticed were clumps of material sitting between the nerve cells. And these we've come to call plaques, and we now know that they consist of a protein material called beta amyloid. Those shouldn't have been there, but they were. And the other thing he saw were tangles that looked like little threads of cotton inside the cells. And these we come to know as tangles. And we know that they're also due to accumulation of a protein, a group of proteins called tau. Now, James will touch on these in his presentation as well. But these plaques and tangles became the focus for research into dementia, into Alzheimer's disease. Now, as I said, those shouldn't be there. They wouldn't be there in the brain of a younger person. So why are they there? What has gone wrong? One way that a lot of people are thinking now, if I can use an analogy, is that the brain is perhaps rather like a factory. And the factory's got a whole array of machines and production lines that are making various components that will result in something much bigger than the sum of the individual machines. Well, the brain is the factory and the cells are the machines. Now, everything was fine when the factory was established. All the machines were bright and shiny new, and they worked at full rate and without failing, with no problems at all. But then imagine if something isn't quite right in the maintenance schedule, and the machines start to accumulate dirt and grime and solidified oil and grease, and then there's wear and tear, and some of the machines start to run slowly, so they're not contributing their part to the whole. You can see where I'm going, that with time, the factory gradually grinds to a halt. And perhaps that's what's happening in dementia. For some reason, the brain's housekeeping is failing. And gradually, some of the cells are in conditions that are such that they can't survive, the cells die, and then they can't contribute to the functioning of the brain. And so just like the failure of the factory, the changes start, and for a while the factory looks as though it's working okay. But as the changes get worse and worse, then the factory fails, and similarly the brain fails. Well, that analogy may help a little bit in thinking about James's presentation and perhaps also the question time. The big issue that we have to resolve is whether the plaques and tangles that you'll hear about, or whether they are the cause of dementia, or are they just consequential, such as the collateral damage that comes from some other malfunction. That's what we've got to find out. We've got to really find out what is the starting point of the malfunction. We can find it pretty easily probably in the factory. It's proving rather more difficult in the brain. So I think now is probably the right time to switch to James's presentation. So there might be just a moment or two's break, I'm not sure, but we're going to switch to that. And as I've said, that lasts for about 30 minutes, and then I'll come back and we'll start managing the questions.
A research fellow. So basically my work is split between NHS care, so I run a clinic on a Tuesday afternoon, and most of the rest of my time is spent doing research. So I work with a team of other doctors who are consultant neurologists. I'm not a consultant myself, and I'm not a neurologist either. And my training was actually in psychiatry, so I have perhaps a slightly different approach in some ways to sort of dementia, but of course we are all sort of aiming towards the same goal of diagnosing people and treating people as best we can with the tools available. So in terms of what I'm going to talk about, I'm going to talk a little bit about obviously what dementia is, how we diagnose it. I'll then talk about the common types of dementia we encounter in clinics, so Alzheimer's, vascular and Lewy body dementia, and I'll finish with an overview of frontotemporal dementia as well. And then the last slide will be a brief overview of what you can do to help someone you encounter who has a dementia diagnosis. Now, so I've got about half an hour. I could talk for a lot longer than half an hour about all these different things. So I will be keeping things fairly brief and concise, but obviously there is, as Mark mentioned, a chance to ask questions as well. And I will do my best to answer as many of those as I can at the end when we've finished talking. So, first of all, before going into what dementia is, I think a good starting point is to talk about what the brain is and how and how that works. So just to orientate yourselves, so on the left side of the screen in red, you'll see the frontal lobe in red. So this is the front part of the brain, as the name suggests, and this is really important for decision-making, problem-solving. It regulates our personality and behaviour. It also includes an important area that's required for speech production. Towards the back part of the frontal lobe, I don't know if you can see my cursor there, you've got an important motor area. So that's responsible for our bodily movements, basically. Behind the frontal lobe, you've got the parietal lobe. So this is really important for orientation. It also contains the area responsible for receiving sensory information from the rest of the body. Below that, in blue, we have the temporal lobe. So this is important for processing information coming through our ears, so auditory information, understanding language. And although you can't see it on this diagram, deep within inside the temporal lobe, you've got a part of the brain called the hippocampus, which is really important for making new memories and learning new information. And we'll talk more about that, particularly in the context of Alzheimer's disease. Towards the back part of the brain, we've got the occipital lobe, which is primarily there for visual information processing. So the information that comes through our eyes is processed at that back part of the brain. The other parts of the diagram, which I won't dwell on too much, are the cerebellum. So this is important for balance and coordinating movements. And then we also have the brainstem, which is responsible for a lot of our what we call autonomic functions. So things that you don't really have to consciously think about. So things like breathing, body temperature, and our swallowing. So the key thing to take away from this slide is not to remember, you don't have to remember exactly what all these different parts of the brain do. The key message here is that the brain has a sort of division of labour. So different parts of the brain do different things. Okay? So what is dementia? So dementia is very much an umbrella term which describes a whole range of different symptoms associated with a decline in cognitive function. I'll use the term cognition and cognitive quite a lot in this talk, and what we're basically talking about is memory and thinking. Okay? On this diagram, you can see the four most common types of dementia, which I'm going to talk about. So as you can see, Alzheimer's is the most common one. It's the one that people tend to think about when you hear the term dementia. But of course, there are these other diseases which cause dementia. So we have vascular disease, Lewy Body disease, and Frontotemporal. There are actually many, many other different types of dementia. Some of them I perhaps wouldn't even know that much about. We're talking about hundreds of different conditions that can cause dementia. But yeah, these are the four I'm going to be focusing on in this talk. So I've already sort of told you what the main feature of dementia is. So a decline in cognitive function, so memory and thinking ability. But what we're also saying when we use the term dementia is that the problems with cognition are such that they are starting to impact on a person's activities of daily living. So they may, for example, no longer be able to drive. They may be struggling to complete chores around the home because their cognitive function is impaired to that sort of degree. Unfortunately, dementia is, of course, a progressive condition. It does get worse over time. And related to that point, we don't have a cure. So we do have some medicines which can be helpful for the symptoms of different types of dementia. But there's nothing which actually slows the progress of dementia. Obviously, there's a lot of research going on to try and find new treatments which can slow progress of dementia. So again, hence why research is very, very important. So how do we diagnose dementia? So there are a few different components which we use to build a picture of what's going on. So when a person comes to clinic after being referred by their GP, they'll have a clinical assessment with me or another clinician. And what we will do is we'll take a history of their problems. We'll find out how their memory and thinking difficulties are impacting on their day-to-day lives. It's also really helpful to get a bit of a picture from someone who knows the person well, so usually their husband or wife or another family member or close friend. And what we also do as part of that process of their initial assessment is, within our clinic, we will do a whole range of blood tests, which are primarily there to look for other things that might be causing problems with memory and thinking. So simply having a problem with memory or thinking does not mean you have dementia. There are lots and lots of different things which can cause these difficulties. So things like, for example, having a vitamin B12 deficiency can cause problems. Having an underactive thyroid can also cause a slowness in thinking. So it's important that we try and identify anything like that first, and hence why those blood tests are really important. We do a range of different cognitive tests. So this is usually done with one of our psychologists, and they will test different aspects of memory and thinking. It's really helpful to do this early, because what would happen is you'll look to see if there's a pattern of problems picked up on those tests, and the pattern of difficulties that you see on those tests can help determine what type of dementia the person might have. We also do brain scans. Within our clinic, we tend to do MRI scans, which use big magnets, and they take quite detailed pictures of the brain itself. It's also really important to do a scan to look for anything else that might be going on, which could be causing problems with memory. So, for example, a brain tumour would be something that we'd want to check to make sure there's no evidence of. In some cases, we do some other specialist tests, and one of them is a lumbar puncture test. What this involves is inserting a very fine needle between the bones of the back, below the spinal cord, and we take a sample of spinal fluid. And when we send that sample off, we can measure some of the proteins involved in Alzheimer's disease, and it can help us refine our diagnosis. So what this test does is basically helps us work out, does this person have Alzheimer's disease or not? This is a specialist investigation. It tends to only be offered by neurology services, so psychiatrists wouldn't usually have access to this sort of test. However, an important point I wish to make is that you don't have to have a lumbar puncture to make a diagnosis of dementia. And of course, if someone did have a lumbar puncture and it was negative for the Alzheimer's proteins, what you're basically able to tell the person is that it's extremely unlikely to have Alzheimer's, but it doesn't really tell you what else could be happening. And hence why you would then need to think about other investigations and tests if the diagnosis is still not very clear. So I'm now going to talk about the different types of dementia. So the most common one is Alzheimer's. And I've got a few different pictures on the screen for you to have a look at. So if you look at the one on the left, you'll see on the left picture, you've got some normal brain tissue there. So you've got the brain cells there. But if you look at the picture just to the right of it, the Alzheimer's picture, you'll see there's a few other things going on. So we've got some amyloid plaques outside the brain cells. So the amyloid is an abnormal protein that becomes sticky and forms these clumps and plaques in people with Alzheimer's disease. And we also have what we call neurofibrillary tangles. So these are a different type of protein that becomes abnormal and forms these knots and tangles inside cells. This disrupts how the cells work and they die as a result. So that's kind of what's happening at a microscopic level. If you look at the middle picture, you'll see two brain slices. You've got a healthy brain on the left, and then you've got a brain slice from someone who had advanced Alzheimer's on the right. And you can clearly see there's a massive difference in terms of the size of the brain. You'll also notice, just see if my cursor is going to appear, so there's a central cavity called a ventricle, which is much larger in the Alzheimer's brain. And if you look below that, you'll see that again, there's you've got a lot of brain tissue loss there. So round here is where the hippocampus sits, which, as I mentioned, is really important for memory and thinking. We've got a picture of the hippocampus on the very right of the screen. It's called the hippocampus because it looks like a seahorse. Now, the hippocampus is the part of the brain that is usually affected first in people with Alzheimer's disease. So the first symptoms that people tend to have are difficulties with their memory, particularly their short-term memory. Other symptoms that people may have include a repetition in conversation. The person may tell someone things that they've already said not so long ago. It can also cause some language problems, so they may have word finding problems, or they may have difficulties with misplacing items. They may keep losing their glasses, their keys. They may also have some other difficulties around the home, for example, leaving the hob on, or going out and leaving the door unlocked. More symptoms will develop over time as more parts of the brain start to become affected by the Alzheimer's disease. Now, how we go about treating Alzheimer's, there are some medications which can be used to help improve quality of life and improve symptoms. So these, what they do is they boost the level of a particular chemical in the brain that's important for memory and thinking. They work in about 50% of people. Not everyone benefits from them. But the purpose of them is to improve quality of life. They don't slow the progress of the illness. Okay. So that was a brief overview of Alzheimer's. The second most common type of dementia we see is vascular dementia. And actually, this also does tend to overlap a little bit with Alzheimer's. So sometimes people will get a diagnosis of mixed dementia, and often what we're referring to is a combination of Alzheimer's and vascular disease. So there's lots of emerging research showing that these conditions are actually linked. And the amyloid sticky protein I mentioned on the previous slide, you can actually get in blood vessels as well, and it can cause a more sort of vascular dementia. So there's quite a bit of overlap. I find vascular dementia one of the easiest types of dementia to teach medical students about because actually a lot of the sort of underlying disease process is very similar to what happens in things like stroke and heart disease. Essentially, in vascular dementia, what's happening is you're getting diseased blood vessels. When they become diseased, they don't work as well, so the blood supply to the brain is not as good. And as a result of that, different parts of the brain start to become deprived of oxygen and other nutrients, and they become damaged as a result. And you can see on the screen, on the slide I've got up now, a scan from a brain, someone who has vascular dementia. And you can, I think, quite clearly see there's quite a lot of white change happening around the middle of the scan, so just outside those black central areas, the ventricles I mentioned before. So this is all brain damage that's due to the blood supply being compromised. Risk factors for vascular dementia are the same as they are for things like heart disease and stroke. So having diabetes, having high blood pressure, high cholesterol, being a smoker, excess alcohol, a sedentary lifestyle, all those things contribute to an individual's risk of getting vascular dementia, as well as, of course, heart disease and all those other sorts of conditions. This is why looking after your heart health is also very much applicable to brain health. So keeping these sorts of things in check with your GP is really important. Symptoms of vascular dementia are going to vary depending on which part of the brain has become affected by the disease. However, people often do have difficulties with concentration. They may find their decision-making ability is impaired, and their information processing speed can be much slower than what it perhaps was before. So really the key point here is that people with vascular dementia may not necessarily present with problems of their memory like they do in Alzheimer's disease, though that can happen, of course. The way we pick up vascular dementia would primarily be through doing a brain scan and looking to see how much blood vessel disease and damage there is in the brain. Again, vascular dementia also gets worse over time, and when you have further vascular events, so when you're having further damage to the brain caused by the blood supply being compromised, you start to develop new symptoms and problems over time. There aren't any treatments licensed for vascular dementia. Really, the way to manage it is clinically is to try and keep these vascular risk factors tightly controlled. So making sure that if there's high blood pressure, that's treated, making sure that blood sugars are well maintained in someone who is diabetic. That's the sort of the mainstay treatment for this condition. The third type of dementia that I wish to talk about is Lewy body dementia. So this does overlap with Parkinson's disease, which I'm sure many of you will have heard of or come across. So Parkinson's disease is another degenerative condition where people have lots of difficulties and problems with movement, and one of the characteristic things they can have is a pill-rolling tremor. Now in Lewy body dementia, what happens is you get another abnormal protein developing. So this is a protein called alpha-synuclein. We don't really know what it does. We know it exists and it's important for brain cell function. What we do know is that in this type of dementia, it becomes abnormal, and much like the amyloid, it forms clumps and lumps within the brain. Now, when you get these abnormal proteins developing in the brain stem, which I mentioned before, that tends to cause a more sort of Parkinson's disease picture. However, if you start to get those Lewy bodies forming in the other parts of the brain that are responsible for cognition, then you can start to develop dementia with Lewy bodies instead. Much like the other types of dementia, you get brain cell death. And I've already mentioned it is part of the Parkinson's disease spectrum. So often you can have patients who have not only the cognitive difficulties, but they may also have some features of Parkinson's disease as well. So I've got Parkinson's disease. So I've got some of the clinical features there that we'd look for in a physical examination. In terms of the other symptoms, actually one of the most striking features that we find in people with Lewy body disease is that they can have quite significant fluctuations in their cognitive function. So they may have periods of the day where their cognition is really affected, their concentration is very poor, they're struggling to process information. But then there can be other parts of the day where it's very different. Their cognitive function is much better and they're much more alert. Another striking thing which we see in people with Lewy body disease is hallucinations. These tend to be visual hallucinations, and they tend to be quite complex in nature. What I mean by that is people often see things like animals or people. Sometimes people actually don't mind having these hallucinations. They accept them for what they are. Other people may become distressed by them. Whether or not someone is distressed by these symptoms, it is used to determine whether we need to go ahead and try and treat that problem or not. Sometimes people can also develop delusions. So there's a particular syndrome called Capgras syndrome, which we've seen in a few of our patients in clinic. This isn't unique to Lewy body dementia. It can occur in things like schizophrenia as well. Capgras syndrome is where a person believes that a person, usually someone that's quite close to them, such as a family member, has been replaced by an imposter. It's a really interesting syndrome. As you can imagine, it's incredibly distressing for the person who holds that delusional belief, but it can also, of course, be very upsetting for the family member that's implicated in this delusional belief. I've mentioned already that people can have movement problems related to the Parkinson's part of the illness. People can also have quite significant sleep problems. So there's a condition called REM behavioural disorder. What happens towards the later part of the night is we enter REM sleep, which is where you have rapid eye movements which are occurring underneath the eyelids as we sleep. This is the part of sleep where people will tend to dream and be able to recall those dreams. Ordinarily, the brain is very clever and it essentially paralyzes the body when you're in REM sleep so that you don't act out your dreams. In people who are developing Parkinson's and Lewy body dementia, that system goes wrong and the body isn't paralyzed during REM sleep. And what that means is that people start acting out their dreams. So they may have lots of violent thrashing movements, perhaps during the later part of the night. If someone has REM behavioural disorder and they've also got problems with their memory and thinking, then we'd really be very suspicious of something like Lewy body dementia. In terms of treating this type of dementia, actually some of the medications for Alzheimer's can be helpful, both in terms of the improving cognition, but also for treating the hallucinations that people experience. The final type of dementia I want to talk about is frontotemporal dementia. So we see this less commonly, and actually, again, it's very much an umbrella term. There are many, many different types of frontotemporal dementia. It also tends to occur in younger patients. So when I say younger, I mean people who are below the age of 65. It again is associated with a whole host of different proteins that become abnormal and affect brain cell function, leading to brain cell death. Interestingly, frontotemporal dementia, or FTD, as I will call it, is more likely to be associated with genetic mutations. So these are spelling mistakes in the DNA. If someone comes to our clinic and we think they have FTD, one of the things that we may do is offer them a genetic test to look for a specific mutation associated with FTD. Obviously, that can have significant implications for family members, particularly children and siblings. So we do liaise with a genetic counselling service as well as part of ongoing care. Importantly, if the person doesn't have a genetic mutation that's associated with FTD, that doesn't mean they haven't got FTD. It could be that they have an FTD due to a different genetic mutation that we just don't know about yet. In terms of how FTD presents, so broadly speaking, if the front part of the brain is affected, the frontal lobe, then that will tend to cause more a sort of behavioural problem. If it's affecting the temporal lobe, it tends to cause more sort of a language difficulty. That's quite a broad simplification. I'm going to just give you a few more examples of symptoms, though, according to that. So the behavioural variants, what can happen is people can become apathetic. They may become disinhibited and behave inappropriately in social situations. So actually, often with this type of dementia, the patient may not always really have much insight into what's happening. It's often another family member or a friend who may have noticed that there's something not quite right. They're just not behaving quite the same as they were before. With a language variant of FTD, as I said, with this you're going to start having problems with word finding difficulty. Their speech may become affected, it may become much more hesitant and non-fluent, or telegraphic is a term that we would sometimes use clinically. Again, with FTD, so there aren't any licensed treatments for this at all. But that doesn't mean there's nothing we can do. There are some medication which can be helpful, and depending on what type of difficulty or problem the person has, that will help us determine what sort of treatments we need to offer. We do also work with other services. So, for example, it can sometimes be very helpful to have speech and language therapy referrals put in as well to help, particularly for those who've got language difficulties. So what I'm hoping I've demonstrated here is that dementia is a very broad term. There are lots of different diseases, lots of different causes of dementia, and they affect people in very different ways. It's not just a case of someone's more forgetful. The most important question, therefore, when meeting someone with dementia is trying to understand what type of dementia they have, because that will determine what problems and symptoms they have day to day. So what can you do to help someone with dementia? I tend to use this for teaching medical students, actually, when they are meeting people with dementia. People with dementia can often be very distracted by other things going on around them, and they may find it hard to concentrate on what you're saying. So being in a quiet environment where there's not lots of competing noise can be really helpful in helping that person to pay attention to what you are trying to tell them. Speaking clearly is important, and also trying to avoid raising your voice. So sometimes people may get irritated, perhaps because I have to repeat something a few times, and their voice starts to get louder, and people walk away and think, well, it doesn't matter, they've got dementia, so they won't remember anyway. But actually, okay, although the person may not remember exactly what you had said to them, the emotional content of what you've said can really stick with them, and they may associate that sort of feeling upset and angry at being shouted at with you when they see you in future. So just because someone has dementia does not mean that it's okay to shout at them and just think, oh, it doesn't matter, they'll forget, because that emotion will stay with the person, and they may spend the rest of that day feeling very upset and angry and may not really remember why. Being patient, obviously, is really important. The use of humour is an interesting one. I think this is one of those points where it's very much about letting the person with dementia take the lead. If they're laughing about their mistake or misunderstanding, I think it's really good and helpful to laugh and have a joke with them about it. If the person is getting really upset and distressed by their mistake, of course, then that probably isn't a good time to be laughing about it. Using simple language is helpful. I think this, again, very much depends on the person that you've got in front of you. So just because someone has dementia doesn't mean that they can't use complicated language. It's about tailoring how you speak to someone according to how they're presenting. Trying to avoid asking too many questions. Asking one question at a time is helpful. And of course, explaining things in different ways. can be really helpful, or giving information in a different format. So, for example, having something down in writing that the person can then later refer to. And finally, it's also okay to ask people what they find helpful. So, in summary, the key points I think I'd like people to take away from this is that it's important to find out what type of dementia someone has. It's important to find out how it affects that individual, because that will vary very much. Even if someone does have Alzheimer's disease, it could be affecting other things that perhaps you haven't thought about. And also find out what is helpful for them. I think that's something that patients really do appreciate. I would just like to thank Brace.
Good. Well, welcome back. We cut off James a little bit early because he was just going to thank a lot of people, which, as you will see, included Brace, but we didn't think that that would add a great deal to the understanding of dementia. Now we come to the opportunity for questions, and I think we're going to be switching to gallery view. If you don't wish to be seen, that's fine. If you want to still be able to hear everything that's going on and see other people, that's okay. Just switch off your own personal video. But the video might help us identify those who might have a question. We've got one question from the chat that occurred during the James's presentation, and I'll come to that in just a moment. But if you've also got a question, one opportunity to let us know is if you are happy and you've used it before, you can go to the participants facility button on your screen, and through that there's the opportunity to press on a little hand, which will come up as a hand in your video window, and then we'll know that you've got a message that you would like to ask. Or alternatively, if you've got your video switched on and you'd like to ask a question, if you just literally wave your hand and let us know, then I'm relying on Emma and Amanda to help me keep track, and we'll try and make sure we come back to you and answer your question. So we've now got several more questions. I have to show my hand straight away. I'm not a medical doctor, so I'm not a clinician, and I'm not a dementia researcher. I've just been involved with Brace for quite a number of years and have accumulated some understanding of dementia. So my responses to the questions may need some follow-up. Now, if we take the first question, which has come from HB Lan or HBLAN, and there are several questions in there. The first part is, does anyone know the incidence of dementia in younger people, i.e. those under the age of 65? I'll answer that in parts. One of the issues that hopefully you will have picked up is that the changes that are starting to accumulate that may lead to dementia may not give any symptoms when somebody's younger. So we don't really know when the underlying changes that will lead to dementia when they begin. And so being able to say categorically about the incidence of dementia with age is rather difficult. The definitive diagnoses, if you're a dementia clinician, is made post-mortem. In other words, although you may have a clinical picture, and you will have heard James say how the symptoms can vary from patient to patient, and there is overlap between symptoms between one form of dementia and another, that's one reason why the definitive diagnosis cannot be made until somebody's died, and the neuropathologist is able to look at microscopical sections of the brain. So there are difficulties in A, diagnosing dementia while somebody's alive, and B, knowing when it might have begun. Now, if you're very sharp, you may have seen in the news today an announcement that there is a promising blood test which detects the presence of the tau protein, the one that contributes to the tangles that are found inside the nerve cells in dementia, particularly in Alzheimer's disease. This blood test is extremely sensitive, and it may be possible that we can detect the very earliest changes, maybe 20 years before somebody starts showing the clinical signs of dementia. So I've hedged that one a little bit, but I must say that there are some forms of early onset dementia which have a genetic origin to them. James mentioned a genetic component to frontotemporal dementia and how that can be genetic and passed on through families. And there's another one which is due to a gene that's called ApoE4, which is about the handling of the beta amyloid protein. And that is probably the form of dementia that Alzheimer's patient had, Auguste Dieter, and it can develop in people who are in their 50s. That, again, the numbers of cases are very small, but it does tend to run in families. And those families know, because some of them have chosen to be screened for this particular gene abnormality. And with enormous generosity, those families have offered themselves very often to help in clinical dementia research, so that through their experience, we may get clues as to what is the starting point. Now, also part of the question was, is the incidence rising? Actually, the incidence is going down, but only in particular age bands. So if we took the population of people who were 65 and looked at the incidence of people dying with dementia of people who are 65 now, it's less than there were 15 years ago. And if we follow that through, it's true all the way through the age band 60 to 65, 65 to 70 and so forth. But the reason the numbers of cases are remaining high is because more people are living to be older. We believe we have some understanding as to why the incidence might be going down. It's because, putting it frankly, people are living better. They've been listening to the messages about, the short messages, what's good for your heart is good for your brain. So giving up smoking, having a sensible diet, keeping your blood pressure low, these sorts of things, making sure you're not overweight. All those things that we hear about, which are good for your cardiovascular system, will help to prevent you from having a stroke or from having a heart attack. They're also good for the brain, and they reduce the risk of you developing dementia. So the incidence at a particular age seems to be going down, but we have more people living to older age. And so that's, if you like, offsetting the benefit, and we still see large numbers of people with dementia, estimate of 800,000 people in the UK in any one particular year. So I hope I've answered that particular question. We've got a flood of ones that are coming in through the chat. Kevin asks, what do you do for the unpaid carer of somebody with dementia and support them so that they do feel supported? And we're aware of that in Brace as a charity. It's not part of our remit, but we know it's very much more part of the remit of the Alzheimer's Society, which splits its activity between what I might call clinical research and also support for carers. And also Dementia UK with the Admiral nurses who will support people in their homes. In clinical research, patients who agree to be part of a clinical trial, they do get support from research nurses. And Brace is proud to be able to support research nurses associated with the ReMemBR Group. That is the group that James works with, so that we're not just finding about the clinical progress of the disease, but we're supporting the patient and we're supporting their carers. So that's probably not an answer to Kevin's question, because I don't have an answer, and it's not an answer that Brace would be able to solve, but it's one that we're very conscious of and one that we know needs to be addressed. Right, so I think it's May Hardy is asking whether delusions and hallucinations are mostly exclusive to people with Lewy body dementia, to which the answer is a qualified yes, but it's not exclusive. So that I could speak anecdotally, but my mother thought in a hospital ward that the Queen was waiting to come in through the door and asked me to go and allow her to come and meet my mother. And my mother-in-law, I remember once had a delusion when we arrived to visit her that the most urgent thing we had to do was to go and take father-in-law's dinner out of the oven before it got burnt. So whether these are disturbances of memory or a delusion or an hallucination is a matter of degree. What is perhaps more worrying is that some of the effects of the disease on people with Lewy body dementia is the upset that it causes. So with mother-in-law and the dinner in the oven, by just going out of the room and coming back in and saying, everything's fine, I've switched the oven off, that then becomes the end of it, and the matter's gone. Whereas with Lewy body dementia, some of the disturbed perceptions that people have can persist for quite some time. Right, we have a question from Nikki, which is much more, I think, to do with the clinical progress of somebody whose relative, whose loved one, whose mother has been affected in the terms of the care and support for her diagnosis by the COVID-19. And it has been a very distressing time for everybody. People in care homes have had their routines disrupted. Their relatives have not been able to visit them. They don't understand what is going on. They don't understand what PPE is. They don't understand why they have to wash their hands and so forth. I just hope, Nikki, that very soon you will be able to have your appointment with the memory clinic and that they will be able to help you. Penny asks about the strength of the link between Parkinson's disease and Lewy body dementia, to which I cannot give a number, but it is only a proportion of people with Parkinson's disease who will have the complication of Lewy body dementia as well. So, in other words, not everybody with Parkinson's disease will develop Lewy body dementia, but if you have Lewy body dementia, you'll have Parkinson's as well. Michael asks, how much does hyperparathyroidism contribute to a diagnosis of dementia? It is a very small proportion of patients with, under the umbrella of dementia, who have whose root cause is hyperparathyroidism. So, if you have hyperparathyroidism, you may have a tendency towards dementia, but in terms of somebody with dementia, it's pretty far down on the list before thinking of hyperparathyroidism as a cause of it. I don't know if that helps. I don't know if Michael, do we have a facility, Emma, for letting people to come back in on questions? Has Michael come up so that he's video active? It's okay. Lorna asks, how do we help somebody with a learning disability and dementia? And that is a new issue for me, I have to say, Lorna, and one that I don't have an answer to, and one that I'm personally going to have to do some research into. I can understand the difficulties for the family of somebody with a loved one with a learning difficulty, because it is very hard to be able to establish some understanding for them of what is going on. So all I can say, Lorne, is thank you for alerting me to that, and I'm sure others, because that is something that I will personally want to follow up, and I'm sorry I can't give a more positive answer myself. Just excuse me for a minute, I need to have a little sip of coffee.
Stephen, just to let you know, Michael's unmuted and on video, so he can reply to your question.
Oh, right. Well, if Michael would like to come in.
Yeah, it was just something that came up a couple of years ago. My wife had a calcium test, which showed higher rates of calcium. And from that, she was diagnosed with having mild hyperparathyroidism,
right,
which, when you read about it, is a possibility that it can lead to dementia, or give the impression it's dementia, also depression and things like that. So it was just a thread, really, that I was just clutching at straws, basically.
But there is a connection, but generally speaking, patients with a parathyroid gland disturbance, whether it's too much activity, as in the case of hyperparathyroidism, which, as you may remember, it tends to drive people to be very active, always on the go. They can cope with not a great deal of sleep, as opposed to the counter, which is somebody with an underactive thyroid gland and hyperparathyroid glands, is that they tend to be much slower and so forth. It's that the clinicians have much better ways of managing them. So hopefully that your wife had good management of her parathyroid disease. And it is perhaps then less likely that it might have contributed to anything else. It's when the disease isn't controlled well that it might contribute to dementia.
Basically, all she was told at that time to do was to take extra vitamin D.
Vitamin D, yeah.
Yeah, vitamin. Yeah, I'm just looking. Yeah, extra vitamin D. Still have to have blood tests, but of course, with the virus thing, we haven't been able to get any blood tests done at the moment. So we probably need to go back and get another test.
Spend some time in the garden, because the sunlight is good for vitamin D.
Okay, thank you.
Thank you very much for your question. Do we have anybody else waiting, Emma, or shall I go back to the questions that are on the chat?
So Nikki has come back after your question, just to specifically ask if the lack of a scan would be a problem when they do eventually see the memory clinic, to see if that would be, if the scan is essential to that diagnosis and help that she's going to get from the memory clinic.
Right. So I'm sure Nikki can hear me. I don't think the scan is going to be crucial. The scan is a helpful tool in terms of building up the picture. So making a diagnosis in any disease is rather like doing a jigsaw. And the more pieces for the jigsaw that you have, the better idea of what the final picture is going to be like. But you can get quite a good view from the, they might ask to do your relative to do some simple memory tests and conversations with you, and that will help them to build up a picture of the illness. And the scan could come later and help add to the story, but I'm sure that they will be able to help you at the memory clinic and start to make progress, even though the scan is having to be delayed. So I hope that's helpful. So if I go back to the chats, we have a question from Beth, which I'll just read on my screen, if that's a moment. Right, so Beth asks a question about if you think your parent has early stages of dementia, what's the best place to start to have a talk about it? And they ask whether the first place is your doctor. The first place should be your doctor. Sometimes doctors find it difficult to have have a chat with you about somebody else who, of course, is entitled to her clinical privacy. And the doctor may not feel that he or she wants to talk about your parent behind their back, as it were. So it can be helpful to have actually a conversation with your parent and then try and go to the doctor together. And that could be the helpful starting point. Sophie asks, my grandpa needs to move to a nursing home, but we know his mixed dementia will worsen. Any advice? The only advice I can offer, to be frank, is anecdotal, which is my father and my mother-in-law. And that is that going to any care home is something that none of us want to do. But sometimes it's a decision you have to make because there are things that you can't do at home. And there is always a wider picture. Sometimes the care in a home can be excellent. And the key thing is actually keeping in touch. So the care home will also respond positively if they know that you are a frequent visitor. So anecdotally, my wife with my mother-in-law, when she was in a very nice and small care home, would go there for the day once a week and have lunch and also engage with the other residents in the care home. And I won't say that influenced the way the care home staff looked after mum-in-law, but it changed the atmosphere in the whole place, to be honest. And there were other care home residents who looked forward to my wife coming, and mother-in-law would get a bit jealous if they got some of the conversation at lunchtime. So I think the key thing is to accept that sometimes a care home, although it's not the decision we want to make, actually in the bigger picture has to be the right decision. And then to make a determination to make sure that you keep in touch as regularly as you can with your relative and bring in their friends to the care home. And remember, because a relative is in a care home doesn't mean to say they can't come out of the care home for a day. They can still come and enjoy family parties. They can still go with you to have a picnic or whatever it might happen to be. So I hope that might help. Penny comments about the Admiral nurses that I mentioned about helping people at home, and I'm glad to see that Penny has had a good experience with the Admiral nurses. Dementia UK, we wouldn't see ourselves as at Brace as being in competition with them. We're all in that same category of trying to find support, help, answers for people and families where dementia hits. With Dementia UK, they've decided to concentrate their energies very much on the support of families and carers. In Brace, 30 years ago, the trustees made the decision it would be very much more on the research side. In the longer term, we must find these answers. We will be having more webinars on various topics around dementia, support for people with dementia and the like. And we hope that you will keep in touch with Brace by going to our webpage where we advertise these events. And remember, well, as you found out today, it's very easy indeed to join a webinar, and you can dip in and out of it as much as you want, and you can leave when you want. So it really is, and you don't have to leave home. So it really is a good way for us to share information, for you to obtain information, and also for us to be able to interact.
Stephen, there's one more question from Lorna asking about Pick's disease. Is it hereditary?
Now, Pick's disease, if I remember, is a form of poisoning. And without going to another device, I think it's linked with mercury poisoning, but I may be wrong. In which case, it would not be hereditary. It would be, very sadly, something to do with a childhood exposure, long exposure to that toxic agent. But don't take my word for it, because I'm just relying on memory, and I'm not going off video to check a book.
That's fantastic.
All right, do we have any last questions? Because if not, perhaps we would then sign off just with the message again that please keep in touch with Grace. Remember that we would very much like your support in whichever way you feel you can offer it, and we would look forward to welcoming you to one of our webinar events in the future. So thank you all very much.
Thank you.